Yes, please.
Yeah. I welcome you all to the webinar series of Cutting Edge. This is the second webinar of the month which we are holding. So Cutting Edge is basically the brainchild of Dr. Meenu Agarwal ma'am, who's president POGS, and we are hoping that it continues for the ongoing year and it will be held every Tuesday evening. At the outset, I would like to welcome Dr. Meenu Agarwal ma'am, who is the president of POGS. She's the secretary elect of ISGE. Can we play the presentation? Mr. Prasad?
Yeah.
Yeah, I would like to welcome Meenu ma'am. I would like to welcome Dr. Vaishali Chavan ma'am, who is the General Secretary of POGS for this year, and Dr. Charulata Bape ma'am, who is the Clinical Secretary of POGS. Also, I would like to welcome all our guests, our chief guest, Dr. Shyam Desai sir, our guest of honors, Dr. Girija Wagh ma'am, Dr. Sujata Darvi madam, and Dr. Bharti Abhyankar madam. I would also like to invite our speaker for the first session, Dr. Parag Beniwale, and our esteemed chairpersons, Dr. Rajesh Kokre, Dr. Meenakshi Deshpande, Dr. Prasad, and Dr. Indraneel Jadhav. So I request Dr. Vaishali Chavan madam to please introduce Dr. Shyam Desai sir, who is our chief guest for the evening.
Thank you, Dr. Madhura, for starting with the introduction. So this is the second session of a Cutting Edge webinars with Pune OBGYN Society has launched. And this is a brainchild of Dr. Meenu, like Dr. Madhura said. And today for this Cutting Edge webinar, we have eminent, very well-known, renowned faculty. And we are truly blessed to have such eminent personalities with us today. So to give up their blessings to us. So I would, it's a proud privilege for me to invite Dr. Shyam Desai. Sir is President CEPFOG. He's past President FOXI. And Sir has also been past President of Mumbai OBGYN Society in 2000. Past President of IAG, Vice Chair ICOG, and Chairman Maternal Perinatal Health Committee FOG. Sir is has been teacher at Mumbai University since 30 years, and I am truly have been blessed to be taught by Sir at Wadia Hospital, because Sir has been honorary Professor Wadia Hospital since past 25 years. Sir, it is indeed a proud privilege and a great honor for us to welcome you today.
Thank you, Vaishali madam. I would request Charu ma'am to just do a short inauguration of the CME today.
Yeah, so before any webinar, any CME, we invoke the blessings of the Lord. So may I request Mr. Prasad to kindly play the inaugural song?
Kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. Take us from darkness to light is what we all wish to achieve in our lives. And who better is here today to guide us than Dr. Shyam Desai sir as our esteemed chief guest for our webinar. Sir, we would want to hear a few words from you and kindly guide us.
Thank you, Charu, for that introduction. It is indeed my pleasure and my privilege to be a chief guest for such a program that you have organized. The POGS has always been at the forefront of societies and activities of societies in FOXI. And I'm so glad to know that POGS is maintaining its reputation as far as this is concerned. Teaming up with the Baramati Society and Kolhapur Society is a wonderful idea. It not only involves people from POGS, but also gives other people from other societies a chance to interact with you. The topics that have been chosen today are excellent. Dr. Parag Beniwale talking on the various methods by which we can make motherhood and childbirth more comfortable for the patient. And of course, Dr. Meenu Agarwal is eminently suited to discuss the various fertility promoting procedures that we can carry out endoscopically. So I'm sure you're going to have a good program, and I'm waiting to hear both of them speak. And I wish this entire webinar a great success. So you, Dr. Vaishali Chavan, and Dr. Meenu Agarwal, congratulations once more.
Dr. Meenu, you would want to say
Yes.
something?
Yes. Thank you so much, Shyam Desai sir. I mean, I have seen him for so many years in endoscopy committee, and of course, as the torchbearer of FOXI and various international organizations. And his blessings we are getting for this webinar is really truly it touched our heart, and very happy to have you here, sir. And we have two speakers, as you said. Parag will be talking now. Parag will be talking on the optimization of labor. And we also have our guest of honor. We have Girija Wagh here from our own city, Pune, Vice President-elect Fox. And then we have Dr. Sujata Dalvi Madam here from MOX Secretary. And we have Dr. Bharti Abhyankar Madam here. So we'll have these three guests of honor, and then we will be taking the lecture, sir. So thank you very much, Charu and Vaishali, for the kind words. And we can introduce the next guest of honor. Thank you.
So we are further blessed to have our very own Dr. Girija Wagh, Vice President, West Zone FOXI, as our guests of honor today. I think Dr. Girija requires no introduction. She has not only been a great friend and right from days of BJ Medical College, and she continues to guide the entire POGS along with so many new aspirants who wish to enter FOXI. She's a great teacher. She's an academician by heart. She's the professor in HOD Department of OBGYN at Bharati Vidyapeeth Medical College, Pune. Not only does she is she the HOD, but she's also a very busy consultant at Cloud9 and Apollo Hospitals. She's faculty professor, OGASH International Experts General Coordinator. She's been the chairperson of the Medical Disorders Committee. She's been the vice president, Indian chapter Justosis, and so many other faculties and so many other posts which she has graced. Girija, you are indeed the pride of Pune and the pride of FOXI too, and we would like to hear from you. Thank you for being with us, Girija.
Thank you so much. If you can take off the share screen. Yeah, thank you for introducing me and most importantly, inviting me. And I'm indeed privileged to be a part of this particular entire thing because it belongs to my POGS. And when especially we associate with Baramati and Kolhapur, who in the societies which are our very, very dear friends, it's indeed a nice time to discuss a very, very simple topics as we can see here in this talk. Vaishali mentioned that Dr. Shyam Desai was her immediate teacher, but let me tell you, Vaishali, we learned a lot of things from Dr. Shyam Desai. And I think he has been a proponent of active management of labor, which was something which was a completely new aspect which we learned that time. And we even practiced it. We had a wonderful labor conference in Pune. And I still remember how these stalwarts in FOXI taught us to look at these simple aspects in our practices. And therefore, I want to congratulate Dr. Charu, Dr. Meenu, and Dr. Vaishali for bringing up this entire, sort of an topics to forehead, because that's something that we have to stick to always. Delivering patients and giving them a good birthing experience is so very important. Simple nuances in laparoscopy, these are very, very important for our day-to-day work. And many times we get carried away by a lot of things which have been spoken. Recently, I was in Jipmer and I saw an intrauterine surgery being done for spina bifida and all those kinds of things. So those are there, they are important, they're happening. But what are our basic important things which we do on a day-to-day basis and deliver them with perfection? And who else to speak about it other than Parag? I know I've seen Parag working very closely, not only as a junior resident, but also as a co-consultant. And I've seen what wonderful volume of work he's doing. So we must learn from these experiences and enrich our own clinical practices. Thank you for having me here and wish you all the best for the webinar.
Thank you. Thank you so much. Over to you, Dr. Vaishali, to introduce Dr. Darvi, madam.
Yeah, such a great pleasure to hear from you, Girija. And now it is indeed an honor for me to welcome Dr. Sujata Darvi. And again, I have been very, very blessed to have seen ma'am working and at KGM Hospital, Mumbai. We would all flock to in ma'am's OT to watch her operate. So, ma'am, it's a great honor for me.
Yeah,
Yeah,
thank
welcome you.
That's
Welcome
fine.
you.
Yeah, yeah.
Ma'am is like Secretary AMOGS, Joint Associate Editor, Jogi, President.
That's fine, Vaishali. Yeah, yeah.
Yeah.
So thank you, Vaishali, for a very kind introduction. At an outset, on behalf of AMOGS, as a Secretary of AMOGS, I would like to welcome one and all for this second webinar on cutting edge and being a brainchild of POGS President, Dr. Meenu Agarwal. I would also like to express our gratitude to Dr. Meenu, Dr. Vaishali, Secretary POGS, and of course, Dr. Charu as a Clinical Secretary. Today's topics are very important and the speakers are equally excellent. So I'm sure those who have logged in will learn a lot from attending today's webinar, and they will be able to implement all that they are learning today for the betterment of the patient. I would also like to acknowledge the words of wisdom given by our chief guest, and of course, kind words given by my co-guest of honor, Dr. Girija. I'm waiting to hear from Dr. Bharti Abhyankar, and I would like to wish Dr. Meenu and her team for their future endeavor in Foxy. Thank you so much for having me here. Thank you.
Thank you, Sujata madam, for blessing us, and thank you for your kind words. And we look forward to having more and more work with the MOGs and with you. Thank you very much.
Thank you.
Thank you so much, madam. And we also have Dr. Bharti Abhyankar, madam, as our third guest of honor for today. Madam is from Kolhapur. She's a consultant at Purva Hospital since 36 years. And she has been running courses in colposcopy for a very, very, very long time. One of the few recognized courses which everybody wishes to attend is Dr. Bharti Abhyankar's colposcopy course. She has been elected unopposed as the Vice President of AMOGS for 2024 to 2026. She's worked as the chairperson on Preventive Oncology Committee in AMOGS, worked as a zonal coordinator in AMOGS, was the first person to start the menopause clinic in Kolhapur, has got a number of publications and presentations to her name. Dr. Bharti, we're eager to listen to you.
Thank you very much, Pune team, for giving me this opportunity to be a guest of honor. I'm really happy that I can share this virtual dais with eminent personalities like Dr. Shyam Desai, Girija, very close friend of mine, and Sujata madam. Dr. Shyam Desai, I hope you remember that we have invited you as a chief guest in UA Foxy, which was conducted in 2009. And you had given a beautiful oration for that. So I still remember I was a secretary for that conference. So today we are having lectures on various topics which are very close to us. The name is very catchy. I just like the name Cutting Edge. It's something different and the name makes us to listen all the lectures. So thank you and best wishes for the Pune team. Thank you, Dr. Meenu, and best wishes for you too. Thank you so much.
Thank you, Bharti madam, for these kind words. And yes, Cutting Edge we thought was a more kind of with some take-home message and something with advanced technology as well as what we are doing every single day. So that is how I find this word. So thank you very much for liking it.
Bharti madam, it's such a pleasure to have Kolhapur team with us, Kolhapur Society, yourself, Dr. Indranil, Dr. Prasad. Welcome along with the Baramati team, Dr. Rajesh and his secretary. Thank you so much.
So without wasting much time, I think let's move on to the first session.
Thank all our esteemed, the chief guest, Shyam Desai sir, and our guests of honor for sparing their valuable time. And for
Yes, yes, Rajesh, you're audible.
Hello.
Yes.
Am I audible?
Yes, yes. Welcome.
Yeah.
So thank you, esteemed chairpersons and guests of honor for sparing your valuable time to bless our webinar. And we declare that this session has been inaugurated, and now we move forward with these scientific sessions.
So for the first session, I would like to invite our esteemed chairpersons, Dr. Rajesh Kokre sir and Dr. Meenakshi Deshpande madam. I welcome you to chair the session. So I'll just give a short introduction about sir. He has been practicing in Baramati since the last 25
Hello.
years. Hello? Yes, sir.
Yeah, you can go on, Madhuri. Madhura.
He's the West Zone coordinator for the Motherhood
Hello.
Committee, and he has a special interest in IVF and high risk pregnancy. Welcome, sir.
Welcome, Dr. Rajesh.
Yes, yes. Hello, good evening, everyone. And first of all, I would like to thank Dr. Meenu and the team for inviting us and having this wonderful session. And so I'm going to introduce today's speaker, our dear friend, Dr. Parag Beniwale.
We also just
He's a
introduced
senior-
our second chairperson for today's session.
Second
Dr.
chairperson is Dr. Meenakshi Deshpande madam, who's the incoming General Secretary POGS for the year 24-25.
Okay. Yes. Okay. Sorry, ma'am.
Welcome.
Yeah.
Yes, sir. You
Yeah.
can introduce.
Welcome. Yes. So for today's first speaker is our
Just a
Dr.
minute.
Parag.
I'll just
Dr.
one word, Rajesh.
Yeah.
Yes,
I would like to congratulate Meenu and Vaishali and Charu for the whole team for this wonderful
Yes.
webinar. Actually,
Indeed. Yes.
Cutting Edge
Indeed.
webinar is a new name, and I think we would like to carry it forward also.
Yes, indeed.
So,
Yes,
yeah,
indeed.
it's a
And,
very
and
nice
he has extended
concept.
this knowledge to peripheral societies
And
like
it is a,
Baramati.
sort
That's
of
the reason
focus,
we would like to
focus
thank
topics
a
and
special thank
focus
from all of
themes.
us from Baramati.
Yes, yes. And we have got excellent speakers also today according to the
hello.
topics. Yes, can go on.
over to you, Rajesh.
Yes, Rajesh, please go ahead.
Yeah, there is some disturbance, I think. Can you hear me?
We can hear you well now.
Yes.
Yeah, okay, fine. So here's the first speaker is Dr. Parag Beniwale. He's a PG teacher and the unit head of the Kamala Nehru Hospital, Pune. He's a chairman elect of Indian College of Obstetric and Gynecology, president of Menopausal Society, Pune. He's the president of Pune OBGY Society 2022-23, and he has been national faculty and national website editor.
Thank you,
And,
Rajesh. That's enough. Thank you very much.
And dear friend of all of us, and a very well academician, and so many PG students acknowledges his teachings from Baramati. Also, Dr. Avinash, he always tells about Dr. Parag. Thank you, Parag, sir. And I request you to start the first lecture.
Yeah. Thank you, Rajesh. Thank you for those kind words.
Parag, one sentence about you from my side. Is the pride of POGS and also now of ICOG.
Thank you. That's very sweet of you. I bring greetings from POGS. Thank you, Dr. Meenu, Vaishali, Charu, Madhura, and the entire team for asking me to speak. And I'm especially happy that Dr. Shyam Desai is here today because the topic which I'm going to talk today, we have actually learned from Dr. Shirish Daftari and Dr. Shyam Desai many years ago. So today we are going to talk about intrapartum care for joyous motherhood. All of us are looking forward to a joyful motherhood. We always believe that a woman who comes in labor should deliver safely, go home with a healthy baby. But this entire process has to be carefully supervised and monitored. And of course, we are now talking about respectful maternity care, where we take utmost care, not only of the physical health of the mother, but also of the mental health. When we talk about respectful maternity care, there are so many aspects involved to it. But today we are going to focus something on intrapartum care. And I must say that this was a concept mooted by Dr. Shirish Daftari, who published it way back in 1977, and then he has redeveloped it over the years, and he termed it programmed labor. But today we are calling it intrapartum care because here this is the protocol for labor management, which is developed with a dual objective of providing pain relief during labor and reaching the goal of safe motherhood by optimizing obstetric outcome. So when we talk about intrapartum care, there are three components that we are looking at. Number one, providing optimum pain relief. So judicial use of analgesics and antispasmodics. All of us know how painful a normal labor is, and if a woman desires to have pain relief, I think it's our duty to provide necessary pain relief. Of course, all of us are aware about different modalities, but this is one modality which really helps a lot of women sail through smoothly and achieve the goal of having a vaginal delivery. It also ensures adequate uterine contractions. So here we are going to talk about active management of labor, which is so important to ensure that the labor also progresses rather smoothly with the end result of a vaginal birth. And the labor monitoring has to be done very, very closely. And here we are also going to talk a little bit about the partogram. So when we talk about program labor or intrapartum care, selection of the patient is important. And this is the data which was published by Gupta et al. In the year 2015, where women who were selected for this particular study had no identifiable medical or obstetric complications. These were primigravida with singleton pregnancy with cephalic presentation, and those women who had a spontaneous onset of labor. The gestational age was between 37 and 41 weeks. On admission, the CTG was reassuring, and the active phase of labor with cervical dilatation of 4 centimeters and 50% effacement was noted. Though the concepts of active phase of labor are changing, this is a relatively old paper, so which refers to at 4 centimeters of dilatation. So the women who were selected were primi or even multi, who were more than 38 weeks, low risk patients. There was a presence of anesthetist and neonatologist for necessary interventions. A due consent was taken after explaining the modality to the patient and the relatives, and essentially this was carried out during the active phase of labor. Now, there were some women who were not considered for this particular method, which included high-risk cases like antepartum hemorrhage, women who had hypertensive disorders of pregnancy or hyperglycemia of pregnancy, polyhydramnios or oligohydramnios, women with suspected cephalopelvic disproportion, women with malpresentation, and of course, women who had pre-labor rupture of membranes. The medication protocol for intrapartum care began only when the patient was in the active phase of labor. So the cervical dilatation was around 4 centimeters or more with an effacement of at least 50%. The uterine contractions coming at a frequency of 3 by 10 minutes and lasting for about 35 seconds. The head should be engaged. There should be no clinical suspicion of cephalopelvic disproportion, and patient may have a show when this was noted at the beginning of the protocol. The medications that were postpartum care, as per protocol, a combination of drug was used, which was coupled with antispasmodic drugs, which helped in cervical softening, yielding, and dilatation to the moderate driving force of labor. And the advantage which was postulated was to provide with benefits of drug synergism, whilst at the same time restricting the doses of drugs to minimal amounts to commensurate with achieving progressive labor, whilst at the same time safeguarding the mother and her fetus against any major drug adverse effects. So the primary goal was to providing optimum pain relief with the use of analgesics, and the drugs that was used was pentazocine. Of course, all women were started with an intravenous infusion line of ringalactate solution at about 20 drops per minute. After ensuring that the pains are optimal, that is 3 to 4 sustained contractions in 10 minutes, and in women who did not exhibit contractions in 10 minutes were added to 2.5 units of oxytocin. Since this was an old study, tablets of primiprost were also given orally in order to ensure that the pains are optimum. Now, 30 milligrams of pentazocine, that is better known as Fortwin, was diluted with normal saline or distilled water, and similarly, an ampule of diazepam was also taken in 10 ml of diluent. So women were administered 1/5 of each drug, that is 6 milligrams of pentazocine and 2 milligrams of diazepam, slowly in the bolus form through the tubing of the infusion lines. So the drugs that were used are there even now, and they have been used in practice for a very, very long time. But the dose that was used was pretty less, and it was thought that it would have the same impact as the full dose of this particular drug. The labor progress was also monitored. Now, the progress of labor was monitored by charting the maternal and the fetal parameters every hour or earlier if indicated, and the labor progress was assessed on basis of cervical dilatation and effacement along with descent of fetal heads, and this was documented on partogram. So when the patient was in advanced labor and the fetal head pressing down on the pelvic floor, typically the patient would complain of severe pain, or she may start getting bearing down sensation. And generally it is noted that the cervix is usually about 7 to 8 centimeters dilated or even more. And this is the time one can think of administering injection ketamine if there is no adequate pain relief. Now, anesthesia during labor, all of us are aware about the epidural anesthesia or epidural analgesia, I should say, and this is in practice for a very, very long time, but in places where the epidural analgesia practice is not being performed because of inadequate number of anesthetists, or if the patients who are coming from low resource setting where the facilities are not available for administering epidural analgesia, this is one area which should be tapped for relief of pain labor or relief of labor pains in order to achieve a smooth sailing through the childbirth process. The adequacy of the uterine contraction was ensured, and here comes the concept of active management of labor. Active management of labor was popularized way back in the 70s thanks to O'Driscoll from Ireland and his colleagues, who reported the advantages of active management of labor, which resulted in shorter labors. It improved the obstetric outcome, and the C-section rate was very, very low. So active management is used to prevent infection, dehydration, ketosis, maternal exhaustion, and fetal distress as far as these women are concerned. The labors are monitored very, very closely, maintaining a partogram, and this is the old partogram which all of us have used. So this is a graphical record of observations made of a woman in labor, but now we've shifted over to a new partogram introduced by WHO, and this is the partographs, which is a comprehensive which tells us about the condition of the mother as well as the fetus. And if you look at the picture carefully, it tells you everything of what is going on in the labor with the baby. It talks about the dilatation, it talks about descent, and it also gives you a space to plan the labor in the right way. And partogram gives you a lot of information. I know this picture is not very clear, but we have to understand labor patterns. And here we can differentiate a normal labor from a prolonged labor and even dysfunctional labor by means of partogram. Now, coming to the outcomes of this particular study. Now, there are 400 women included in this particular study. So 200 were controls, 200 were from the study group. 176 women out of the study group had a vaginal delivery, which was almost 88%, while 162 women out of 200 from controls had a vaginal delivery. But what is more interesting is about the duration of active phase of labor, which was shortened to about 3.5 hours instead of 5.2 hours. the mean cervical dilatation rate was much more, almost twice as that of women who were in the control group. The second stage was much shorter. The third stage was very short with a good pain relief to all of women and no perinatal losses. So this slides gives us a comparison of all these parameters like the rate of cervical dilatation, duration of progress of labor, and it also talks about complications in both the groups. So the results of this study said that the rate of cervical dilatation was 1.72 centimeter per hour in these cases, and as against 1.23 centimeter per hour in control group. The duration of active phase of labor was significantly reduced. The duration of second stage was significantly reduced. Majority of the patients in both the groups delivered vaginally. 86% of the study group had pain relief as compared to 22% in the control group. Mind well, which is definitely statistically significant, and it will definitely have a positive impact on the minds of the women when they think about their future conceptions. The cases had significantly more drug-related side effects like nausea, vomiting, and these subsided within about 12 hours. And there was no significant fetal or neonatal complications in either group. So both these studies talk about the benefits of intrapartum care of labor and how it is useful as far as progress of labor is concerned. The next aspect is about this antispasmodics. Now, antispasmodics also reduce the duration of labor rather significantly when used at the right time in the right dose. So when we talk about antispasmodic vis-a-vis control, there are definite benefits as of using antispasmodics. So the labor is going to be short. The duration of the second stage of labor will also be short. Similarly, the third stage of labor was also found to be lower, and the mean rate of cervical dilatation was much higher in the antispasmodic group as compared to the control group. Coming to the commonly used drug, that is valethamide bromide or epidocin, and there is good amount of evidence which supports the use of epidocin. We know that the antispasmodic drugs or the anticholinergic drugs, this is the classification which is shown very, very clearly in the slides. These include neutral alkaloids like atropine, hyoscine. Hyoscine is something which some of us have used in the past. Semi-synthetic derivatives, and there are synthetic compounds which include valethamide, which has been used for management of active management of labor. So the uses of this anticholinergic smooth muscle relaxant is to hasten the dilatation of the cervix when the same is delayed, and the dose that is used is 8 milligram injection, which can be repeated as and when required. Oral forms are also available, but most of us are using and have used in the past the injectable form during the course of labor rather than the oral form. When we compare two drugs, drotaverine versus valethamide bromide, because these are the two most commonly used drugs for active management of labor. So the research has very categorically said that the rate of cervical dilatation under the influence of these two drugs was significantly higher as compared to the control group, and these two molecules had an equal modality of dilatation of cervix. So a single dose of 16 milligrams of valethamide bromide was administered via intravenous route, randomly selected 35 nulliparous and 37 multiparous women. And what they found out was the mean time from complete cervical dilatation to delivery was about 20 minutes in the groups that received valethamide bromide, and 25 minutes in the group that did not receive valethamide bromide. So the study concluded that valethamide bromide significantly shortens the second stage of labor, especially in nulliparous women. And probably these are the women who have more pain and these are the women where we would wish to deliver them rather fast. Of course, there are certain side effects which may be noted. Now, the side effects are not greatly significant, but we do come across side effects like tachycardia, flushing, dry mouth, fever, headache, and nausea and vomiting. Though these are not very common, these can be noted in any woman who's in labor, whether she receives these medications or not. And there was no statistical significance that was found when these drugs were used between the age group of 18 to 25 and 26 to 35 years. So irrespective of age, there was no adverse reaction noted with hyoscine and valethamide bromide. One more study which talks about rotavirine versus valethamide, and here we do see that the headache and even cervical tears were less noted in valethamide group. So that brings us to the advantages of intrapartum care. First and foremost, it shortens the labor with substantial pain relief, which is so important, especially in primary gravid patients. There is significant amnesia of painful events of labor, and this would probably have a better impact for the future when the future conception is desired. The average blood loss was found to be less. The duration of all these three stages of labor was markedly reduced, which is so important because the patient is delivering rather fast. The obstetric management in general was found to be simplified. There was lowering of incidence of operative deliveries because of adequate pain relief. The people were able to achieve a vaginal delivery, and of course, neonatal mortality was similar to that of control. So thank you very much. And once again, thank you, Team POGS, for having me here for this presentation.
It was a
Maybe request Dr. Shyam Desai to give his remarks because
that was what
he's
I was
one of
going.
those who really popularized this particular technique about more than 2 or 3 decades, I should say.
Thank you, Parag, for inviting me to give the comments. It was a wonderful lecture. In fact, I almost felt that I was delivering it because it was so well organized and so well described. And I'm glad you have brought out all the various salient points that Dr. Daftari had emphasized. And pain relief, better supervision, partography, making sure that the patient is well hydrated. And that certainly reduces the stress of labor, and that is what we would like to make sure. In fact, this year we have in SAFOG also we have tried to bring in the topic of respectful maternity care, which obviously would include a well organized and well supervised labor as well. Now, when we were doing these workshops all over the country, there were many people who said, but there's nothing new in this. We do an ARM at 3 centimeters, or we start a Pitocin drip when there are no pains, or we monitor a partogram. So what is this new that you are putting in this particular, optimizing labor or program labor? I said the very fact that we are bringing in all these various modalities under one particular roof and making sure that we're doing all these things correctly. So, and we're supervising the labor also a little better. So that makes it a easy thing for obstetricians to follow. And you're right when you said that when epidural is not available, this analgesia that is afforded by pentazocine and diazepam, 6 milligrams and 2 milligrams, is an excellent way of getting the patient to relax during labor, and relaxation of the mind results in relaxation of the cervix. And we have found patients who are stuck at 1 centimeter and 2 centimeters. With the help of analgesia, they dilate so rapidly that within the next 1 hour, the head is on the perineum. And then they said that, oh, well, the ketamine that you're recommending, it can be harmful to the baby. So we had anesthetists who said that, well, the ketamine that they are giving, in the dose that they are giving, will in no way harm the baby. And it is, in fact, only beneficial that this ketamine should be given so that the patient is relaxed when the episiotomy is sutured. So it is a wonderful lecture, and I'm so happy to have heard it from you because you are a strong proponent of our.
Yeah, thank you, sir.
Thank you, sir.
Am I audible? Am I audible?
Yes,
Yes,
Meenakshi.
Meenakshi.
Yes, yes.
Thank you, Desai sir and Dr. Parag Beniwale. This was an excellent deliberation on this topic. And I think it is a need of the hour that we should reduce the stress and the anxiety of the patients in labor, because that is going to give us much better results, not only intrapartum, but immediately postpartum also, when we want patient to relax for whatever procedures we want to do. If we have applied a forceps, a deep episiotomy, suturing of deep episiotomies, that going around looking for the cervical tears. I think all this will require this sedation, and ketamine dose will be helpful for that also. Excellent pulse of wisdom, sir, from both of you. And Dr. Parag Beniwale has given the best lecture, I think, on this topic. So thank you, both of you. And any, you can say, comments from the guests of honor if you want to give. Dr. Bharati Abhyankar, Dr. Girija.
Incidentally, this year's theme of our POGS is respectful motherhood. And Parag has really justified that theme in his talk. Thank you, Parag.
Superb talk,
Thank you.
Parag. As always, fabulous talk. Really enjoyed and learned a lot. Thank you.
Dr. Madhura, please unmute yourself.
Oh, sorry. So thank you, sir, for the great talk. For the second session, I would like to invite both our chairpersons from Kolhapur, Dr. Prasad Halkarnikar, sir, who is the president of Kolhapur Obs and Gynaec Society. He has been practicing at Sneh Hospital at Kolhapur, and he specializes in vaginal surgeries and infertility. Welcome, sir. Our second chairperson for the session is Dr. Indraneel Jadhav, who is a consultant IVF specialist and a gynecologist from Kolhapur. He's the secretary of KOGS and is also associated with Nova IVF. Welcome. I would like Dr. Prasad Halkarnikar, sir, to say a few words and welcome our second speaker.
Thank you, madam. Thank you for the kind information introduction. I thank you, Dr. Minu Agarwal, madam, and team POGS for inviting me and KOGS to be part of this cutting edge webinar. And the topics are very good of interest, and thank you for selecting these topics. I would like to introduce madam. Dr. Minu Agarwal is President of Pune Obstetric and Gynaec Society. She is elected Secretary General, International Society for Gynecological Endoscopy. She is Chairperson of FOGSI Imaging Science Committee from 18 to 21. She is Bachelor in Reproductive Endocrinology Surgery of European Board of Certification. She is Course Director of Endoscopy and ART Training Course in UAE. There are over 12 publications in international journals to her credit. She is first author of 4 books and authored many chapters. She is Bachelor in Reproductive Endoscopy Surgery. She has got India's Greatest Leaders Award by Asia One and Icon of Health by Times Group and Inspiring Gynecologist of West India. She is FOGSI's Champion of FOGSI Awards. Next, over to madam.
Yeah, thank you, Prasad sir, for such an elaborate introduction. And thank you, Kolhapur Society, for associating with POGS. It's really an honor for us. Both Baramati and Kolhapur Society are very close to our hearts, and I'm very happy to have both Dr. Indraneel and you, sir, Prasad sir, with us.
Thank you, madam.
And,
Thank you, madam.
thank you, sir. And today my topic would be on fertility enhancing surgeries or the fertility preserving surgeries. So that is what I'm going to talk. And I'm very happy Dr. Indraneel is here because there is a lot of infertility also with this particular topic. So, it will be better that we can discuss if there are some points related to infertility that we need to, especially related to IVF or ART, that we need to discuss. So when I talk about fertility enhancing or fertility preserving surgery, these are absolutely, I can say, the other end of the sea that we are looking at coming from the respectful labor. So when we talk about fertility enhancing, suppose a patient has a large fibroid. So we first of all, we are improving the results of her infertility, but also suppose she has pain, she has heavy bleeding. So all those things are also managed for the patient in long term. And they go on increasing, especially endometriosis, fibroids. So if you operate it at the right time, that will also help us for a long-term management. Before we start with the topic, first is when not to do a laparoscopy. I think now the time has come that we all have to also answer ourselves when we are taking the patient on in the OT. So very, very clear guidelines, lot of medical legal things and other things have come in now. So when not to do a laparoscopy, very clear guidelines by ASRM before IUI. So before IUI, there is no indication to do a diagnostic laparoscopy. Another thing, even if you're doing a diagnostic laparoscopy or hysteroscopy, very clear guidelines like Manish always says, do not write diagnostic, write fertility enhancing or fertility improving, because diagnostic has no role even in a medical legal case. So why should we not do a laparoscopy before IUI? If everything else is fine, you have seen the fallopian tubes are patent, you have done maybe an HSG or SSG and the tubes are patent, and an amazing good ultrasound. Husband semen analysis is normal or mild oligo, ultrasound is normal, tubes are patent, we can go ahead with 3 to 6 cycles of IUI without subjecting the patient to any diagnostic or any laparoscopy. ASHRAE went one step ahead. You know, we used to say that in endometriosis, laparoscopy is the gold standard. This ASHRAE guidelines 2022 said that either you are doing a laparoscopy or you are doing a good imaging combined with empirical treatment. Both are equal. There is no superiority of one over the other. So you can do either. You can either do a laparoscopy or you can also depend on a good imaging and put the patient of empirical management. So that completely changed the whole scenario of laparoscopy for endometriosis. So whenever we are talking about endometriosis, how do we decide which patient requires surgery, which patient does not require surgery? A lot depends on, number one, of course, age of the patient. What is her duration of infertility? Is she having any pelvic pain? What is the stage of endometriosis as per the imaging? Then when we have put in the laparoscope, whether it is stage 1, stage 2, if it is stage 1 or stage 2, we treat it at laparoscopy, followed by either observation or we can do a minimal stimulation with IUI, provided the patient is young or she has a good AMH. Then we have another patient, same pelvic pain, infertility. If she's an older patient, she's more than 35, again, this particular patient can be treated with a couple of cycles of IUI or we'd go for IVF. Stage 3 or stage 4, there is not much of data whether laparoscopy is better or IVF is better, but most of the times we think that it is better to take the patient straight for IVF. Now, when we find mild to moderate endometriosis, see, you see this endometriotic patch over here. So what we do is we take a diluted vasopressin. How do we dilute it? We take 1 ml in 100 ml of, or you put 6 drops in 100 ml of normal saline. That is how it is diluted. And then just inject little bit below the peritoneum where you find the endometriotic patch, especially if it is overlying the ureter. So you can just resect this and also send it for a histopathological examination. Sometimes we may find these nodules which are scattered all over, small nodules scattered all over. There, what we can do is we can use a bipolar and then just bipolar cauterize. Now, very important here is to take a sponge on a sponge holder and put it on in the pouch of Douglas. And that will, sometimes there are nodules in the pouch of Douglas, which you can, this video is not running, so I will skip it. So those nodules should be coagulated. So you can see here, there is a sponge on sponge holder in the pouch of Douglas, and you can coagulate. Another important point is just behind the ovaries. So we should not miss that. Just lift the ovary up and look at those small nodules behind the surface of the ovaries, and then just gently touch and go on these nodules. So what are the ASHRAE guidelines? So ASHRAE guidelines clearly tell us that if you identify endometriosis at laparoscopy, then you must treat surgically, as this is effective in reducing the endometriosis associated pain. Suppose we have a small cyst. Okay, now whenever we are operating the patient for endometriotic cyst, there are two possibilities. One is we can do a cystectomy, and secondly, we can do a drainage. Very, very important again in these patients is once we have given an incision, this is the most important step, is to put your suction irrigation cannula just behind the cyst and lift it up, behind the ovary and lift it up. So this is the most important point, because this will improve your the relationship of tube with the ovary, and then you coagulate the base. Now, whether to do a drainage or to do a cystectomy is a question mark, but clear guidelines. If we do only drainage, it is not recommended because it has got a high recurrence rate. However, if you do a cystectomy, you must be ready, prepared that that is going to reduce the ovarian reserve of the patient. So a good ultrasound with antral follicle count, also the AMH values of the patient, age of the patient, all that is important before we take the patient for a surgery. So this is how this video is. This is how you do a cystectomy. So what we do is, again, we take diluted vasopressin. You can either inject just underneath, but if you try to do that, sometimes you may puncture, it may puncture the cyst. So you can go into the mesosalpinx and inject vasopressin. It just finds its own way, and then you can do a decent cystectomy for the patient. So this lady, she's a 31-year-old lady. She has a primary infertility 3 years. Male factor is normal, severe dysmenorrhea, dyspareunia. Ultrasound shows bilateral endometriomas 4 centimeters and 5 centimeters. She's come with 3 cycles of IUI done outside. Her tubes are patent. Her AMH is 2.9 nanogram per ml. So what do we advise to the patient? So I'm sure most of you will agree that she is young, number one. Number two, her AMH is good. And number three, we have a reason to think that this could be the reason for her infertility, and she also has pelvic pain. So this particular patient, probably we can counsel the patient, and this particular patient, we can go for a laparoscopy, and then she can go for either just observation, or we can put her on minimal stimulation and 3 to 6 cycles of IUI, during which time she should conceive. Again, important thing is that we must repeat her AMH after 3 months, counsel her that her AMH can go down after the surgery. So tomorrow she should not come and say, doctor, you did not tell me that my ovarian reserve will go down with the surgery. So I always feel in a patient with endometriosis, medical management, surgical management, most important management is the counseling. So before we go for, because nothing is perfect in endometriosis, so counseling is very, very important for such cases. So this particular patient, why we can go for surgery, because endometriosis does affect fertility by making the endogenous environment not so good for oocyte or an embryo. There are many studies where they have taken oocyte from a lady who's suffering from endometriosis and from a lady who's not suffering from a endometriosis, and they have found lesser pregnancy rates with women who are suffering from endometriosis even in a donor recipient cycles. So we discussed about excision already. So we must perform excision instead of drainage, and that would improve their pregnancy rates. As I said, counseling is very, very important. Now, similar patient, if she had already low ovarian reserve, so same patient comes to us, she's 31 years old, but her AMH is 0.9. All this is same. And we see AFC just 1 or 2 on each side. Then we don't go for the surgery and we can straight away take her for IVF, because if we go for the surgery, we are further reducing her reserve and her AMH. However, surgery sometimes may still be required if she is having severe pain. So only for pelvic pain after freezing her eggs or the embryos, we can go for the surgical procedure if she wants a a segmented embryo transfer. Then we have again this lady, this we already, okay. So she's 33 years old, similar case scenario, but she's not married. Here she's unmarried. Her complaints are only dysmenorrhea and dyspareunia. She also has bilateral endometriotic cyst. Her AMH is quite decent. What next? So this particular case I put it because in another meeting I was also to speak on preserving. So this is the girl, suppose we have our own daughters or we have a friend's daughters and they have this kind of a complaint. These are the girls who should also be advised for a egg freezing. So egg freezing is a good option for them. We can go for the surgery, wait for a couple of months, and then go for the egg freezing for them, because endometriosis per se, as well as post-surgery, does reduce the fertility and the egg count. So this, I think, all right. So we can either do the egg freezing, embryo freezing if she has a steady partner, or married but does not want to have a child right now. Or in some patients, we can also do ovarian tissue freezing. AMH values, there were a few studies. This was an old study where they said they reduce approximately 40%, but the recent studies have shown that they do reduce, but then subsequently, if you repeat it again, suppose you have done the surgery today, after 1 month we repeat, the AMH is gone down, you repeat after 6 months. And many a times you will find, even it is my experience at our center, that the AMH tends to rise again. So maybe it's just, so don't do AMH immediately after 1 month. I feel we should do it after 3 or 4 months so that we are, the AMH is more settled and then the patient gets less anxious. And should we do a surgery for a patient? Suppose we have a patient, she is for a male factor infertility. She also has endometriosis. She is for ICSI. Should we remove her endometriotic cyst before referring the patient to an IVF center? Again, very, very important question to us. What do the guidelines tell us here? If we take the patients who were treated, who were operated, or who were not operated, they found similar pregnancy outcomes in both the groups. However, in the patients where surgery was done, they had a lower antral follicle count, they had a higher dose of FSH, and they took longer to conceive. So that is also very, very important point for us to understand. So there is no evidence that cystectomy prior to IVF or the ICSI improves pregnancy rates. So these are again very clear guidelines. The patient has an endometriosis, she is for ICSI, maybe for poor AMH, maybe for male factor, maybe for long-standing infertility, for any reason, then we should not operate on that patient. Only surgery is when it is required if she has pain. So cystectomy before ART, it is only to improve endometriosis associated pain or if it is coming in the way of your pickup, it is very large, or you are suspecting any type of malignancy. Again, very, very important that if we are planning a surgery, repeat surgery, you have to think 10 times rather than, even if she has a good AMH, rather than going for repeat surgery, it is better to take her for IVF. So endometriomas, not only post surgery, but per se also, they reduce the ovarian reserve as compared to patients who of the same age who do not have endometriosis. So, and of course, if very severe endometriosis, large cysts, bad adhesions, patient is for IVF, there is no evidence that any treatment of these endometriomas prior to ART versus expectant management would increase the pregnancy rates. This was a patient, she had a AMH was very, very low. She went in for a oocyte donation cycle twice. She had a large cyst of 8 centimeters, no pregnancy. She said, Doc, I have spoken to my sister in the US and she said, you go for the surgery. Maybe because of the endometriotic cyst, you are not conceiving. So we had a 4 blastocyst frozen. So we transferred. We went for the surgery for her because she insisted on the surgery. And it was a large cyst. We just went at the base, as you can see here, and just resected the endometriotic cyst. And then after the surgery was done, we went in for the next cycle for her. Next cycle, again, we transferred 2 blastocysts, but no pregnancy. So then in the 4th cycle, of course, she conceived with a twin gestation and carried the pregnancy till term. But why I'm saying this is because here the patient insisted. If suppose we tell the patient, okay, do this and this will improve your pregnancy results. So sometimes, you know, you are answerable in that case to the patient. So we must individualize the treatment for fertility, and this I can, all right. All right. So as I said, mild to moderate endometriosis with good ovarian reserve, these are the patients where we may go in for surgery for the patient. Then suppose a patient has large adenomyosis, you know, big size uterus. So sometimes these patients, again, very, very difficult to treat, very low chances of their getting pregnant, even if we go for a donor egg, older group patients. So what we are now doing is we are kind of debulking and then closing it in 2 layers. So we superimpose, you know, like we wear that flap kind of kurta. So one thing goes inside and the other flap goes above the first one. So this kind of surgery is helping. We have right now a few patients who could conceive, although the pregnancy rates still are about 15 to 20% in patients with adenomyosis, but the scar is not giving way. So that is important. And I think I always salute the person who thought of bringing in these barb sutures. You know, this was out of the box thinking of barb suture, and it is really helping, especially for patients with adenomyosis, where the suturing was what was giving way, and that is why these patients could not carry the pregnancy. Again, very, very important whenever we are doing an adenomyosis or a fibroid surgery. Sometimes these fibroids are very deep. See here we can see. So it is very important then you take methylene blue and push diluted methylene blue if you are even doubtful that you might have breached the cavity. Does not matter even if you have breached the cavity. Only thing is we should go close to the fibroid, and our assistant should push this endometrium inside. And when we are suturing, do not take the endometrium into your sutures. So these are some things that we must understand and we must keep in mind. We did have one myomectomy scar ectopic, very, very rare case, which we managed laparoscopically. Probably one of the reasons could be that the endometrium came into the scar and we published it. It is in 2017, Dr. Madhuri Kashyap and myself, Sandhya was also there. So this was the first published case of laparoscopic management of myomectomy scar ectopic. If we have a patient who has an adnexal mass, she's for IVF or she's for IUI, first important thing is forget about the fertility part. Think about only the adnexal mass. First of all, we must rule out malignancy. Suppose it is a simple cyst, we can put her on a oral contraceptive birth control pills, wait for a couple of cycles, it should go away. Simple cyst, we can, on imaging, we know it is a simple cyst. But if it is a dermoid or if it is a complex cyst, this has to be taken care of. As in endometriosis cyst, even any other cyst like a dermoid cyst or a serous cyst adenoma, whenever we are operating on these cysts, this will also reduce the ovarian reserve of the patient. So again, counseling, very important. Rule out malignancy, operate these patients obviously will require surgery, and then go for the fertility management for these patients. And then, of course, sometimes we do get bad pelvic adhesions. These patients, she was an anesthetist and had bad, you can see here, bad genital. It turned out to be genital cox actually. And see the pus coming out here from the ovary. So these patients also probably require surgery before we either we go for IVF or for IUI. Sorry. All right. So this was again a very unusual case here. It was many years ago. That time we were not doing any scratching or any hysteroscopy before IVF. So I took the patient. We were only doing day 2 transfers at that time, I think more than 15 years ago. We took this patient and we could not find the cervix. So we put the speculum and no cervix seen. So tried our best. So there was no cervix seen. We told our embryologist to freeze the embryos. That also we had to get, stuff from the other IVF lab. We froze day 2 embryos and then we did a laparoscopy for her. And you can see here, this fundus was adherent to the anterior abdominal wall, completely pulled up. And so sometimes we can get some cases like this for infertility. Laparoscopic electrocauterization of ovarian surface, I think I have not done for the last maybe more than 5 years. So I will not talk about it. Bilateral hydrosalpinx again should be resected before the patient goes for IVF. Very small tip that whenever you are doing a big hydrosalpinx and you are not, this is simple one, but you are not able to see the bowel from the tube, just tell your assistant to intracervically push some diluted methylene blue. The moment you put methylene blue, the tube will get bluish in color. These are all blocked tubes, and you can then see bowel separate from the hydrosalpinx, and your resection will be much easier. Isthmosil again now very commonly seen in patients with previous sections, becoming a more than, in fact in Dubai we had 2 days conference only on isthmosil, and I had a 1 hour debate on whether it should be done hysteroscopically or it should be done laparoscopically. So all my friends here who are doing ultrasounds, please look for isthmosil even if the patient does not have any symptoms but with the previous C-section. So then your eyes will get used to looking at isthmosil when you actually have a patient coming with post-menstrual bleeding, post-menstrual discharge, or secondary infertility with the previous history of C-section. We can manage it both hysteroscopically or we can also manage it laparoscopically. We must look at the residual myometrium. If it is more than 3 millimeters, then we can go for hysteroscopic resection. Or if she does not want pregnancy, she only wants to get rid of her post-menstrual bleeding or spotting, then we can go in for a hysteroscopic management. However, if the patient does want pregnancies thinned out, the residual myometrium, those cases can be managed laparoscopically. And once you have pushed the bladder down, given an incision, we must remove this thickened scar tissue. All of this should be removed, all this thickened tissue. Keep a dilator in the uterine, in the cervix, so that will help you to know which is the lower segment, which is the upper segment, and then take a barb suture. It is a very, very simple surgery, believe you me. There are no vessels. We have to just dissect the bladder and then suture it back again. So, minimally invasive surgery, as I said, is a boon. I have not covered hysteroscopy here, only laparoscopic surgeries. Some of the laparoscopic surgeries, it is a boon for fertility enhancement. Whether we should do any surgery for patient already going for IVF, whether the hydrosalpinx should be removed, biosalpinx should be removed, which patients need to go for myomectomy. If there are any questions, we can discuss them. And we must also know that if she has adenomyosis or adenomyoma, even after surgical management, the results are not very good. So they should be counseled. Only 15 to 20% results of conception after this surgery. So thank you very much. And if there are any questions, we can take them. Thank you so much. Thank you, sir.
Yeah, that was a nice interactive session, ma'am. Actually, it feels a pleasure for me for the sharing the same screen with ma'am, who has sometimes taught me, and also we had quite good conversation regarding fertility before also. Just here, I want to highlight regarding 2 to 3 aspects which were told by ma'am. Actually, fertility enhancing surgeries may be a double-edged sword. If at all done with precision, with skill, with expertise, can help in improving fertility. But the other or downside of that is that if you resect more endometrioma, you are compromising the fertility. If you resect more adenomyosis, you are able to damage the endometrium. If you are not able to take out intramural fibroid, then your surgical is a failure. So with skill and expertise, only fertility enhancing surgeries should be indicated. Is the first conclusion what I get from ma'am's presentation. And the second conclusion which I think should be offered to the patients is, suppose that you are in capacity to have antral follicular counts to be seen and to be grown with IVF. Fertility enhancing surgery should be a call taken after how many embryos are formed, and if at all we are in capacity to transfer those embryos in the implantation zone or not. Suppose that if the implantation zone is fine and you are able to transfer embryos and you have 6 embryos, you can just give a chance without doing fertility enhancing surgeries that if she is getting pregnant or not. Third thing, mostly what ma'am told, it is not about what is the success rate or what success we give with that surgery. It is the counseling which is of prime importance. Sometimes with doing fertility enhancing surgeries and transferring embryos, as ma'am had given a nice example, there was failure to conception. So patients should be aware that with spending this much of money on fertility enhancing surgery is not proving 100% result to her. We are in capacity to reduce the risk and improve the benefit. So we may not know until and unless we give them a chance. So I think these 3 things may be of prime importance. If any other faculties have any questions, they can just share. A nice presentation, my ma'am.
Thank you. Thank you. Thank you, Nitin.
I think Vaishali ma'am has some questions to ask.
No, this is a wonderful talk, Meenu. Always a great pleasure to hear you speak on different topics, and really learned a lot from you, and wonderful videos and surgical skills. So excellent.
Thank you. Yeah, thank you, Vaishali. Thank you, Charu. And thank you, Dr. Indranil, for these nice comments. I think you've really summarized it very, very well. And I agree with you, especially, suppose you have an intramural fibroid, 4 centimeters, no other cause of infertility. You don't know whether to remove it, not to remove it. you freeze the embryos, you transfer once, you counsel the patient. If she does not conceive, or she conceives and she has a early pregnancy loss or something, then second time we can go for a removal of the fibroid and then go for the transfer. So all these combinations, permutation and combinations, I think in infertility with the good counseling is they are very, very important. So I totally agree with you on all the very nicely, you have put everything together at the end. Thank you very much.
Thank you, ma'am.
These are Meenu Madam's words of immense experience, and we are all benefiting from it because of the cutting edge webinar. With that, we come to the end of our scientific session for today evening. And indeed, it has been a great pleasure to be a part of the second episode of the Cutting Edge webinar series. I propose a vote of thanks as we come to an end of this session. I think it is Dr. Meenu's fantastic decision to have only 2 talks so that we can talk in depth about each topic, and questions can be asked, there can be deliberations made. So Dr. Meenu, first and foremost, thank you so much for coming up with this fantastic idea and making us a part of it. We are very fortunate today to have esteemed chief guest and guests of honor in the form of Dr. Shyam Desai sir, past President Foxy and current President Suffolk. Our guests of honor were none other than Dr. Girija Wagh madam, Dr. Bharti Abhyankar madam, and Dr. Sujata Dalvi madam, who have spared their valuable time to give their inputs regarding this webinar. Thank you so much, each and every one of you, for having joined this particular program. We thank the Baramati and the Kolhapur Obstetrics and Gynec Societies for partnering with us. And we thank all the esteemed presidents and general secretaries of these societies, Dr. Prasad Halkarnikar sir, Dr. Indranil Zadhav, Dr. Rajesh Kokre. Unfortunately, we could not have Dr. Ajit Deshmukh with us because of a personal problem in his family, and he conveyed his inability to be a part of this program. So our best wishes with Dr. Ajit Deshmukh for his father's speedy recovery. We thank our own Dr. Meenakshi Deshpande for being the esteemed chairperson for this session. And of course, this program's highlight talk, the intrapartum care by Dr. Parag Biniwale, was again a stupendous talk which benefited each and every one of us. Dr. Vaishali Chavan madam has always been a pillar of support as the General Secretary of POGS, and thank you so much for being here. Dr. Madhura, you are, I cannot say budding, you are blooming so fast. And, at such a young age, you are able to conduct these programs so beautifully as the MOC. Thank you so much for being here. Last but not the least, BSV has been a solid support behind our cutting edge webinar series. And it is only because of their support that we are being able to conduct these sessions so beautifully. So Mr. Prasad and the rest of the team of BSV, thank you for being our academic partners for the same. With that, we come to the end of the formal session. And if we can all have a 10-minute fun session, we are open to that. Dr. Prasad, Dr. Rajendra, Dr. Indranil, Rajesh, any input from your side? We are more than happy to listen to them.
Yeah, thank you, Charu. It was a wonderful session today. Both the lectures were really very helpful. But I just would like to add for the laparoscopy as fertility enhancing surgeries, always that should be combined with hysteroscopy. I feel that one should always put a scope at the same time dealing with the intra-abdominal pathology, as we said, because of the simultaneously you can treat any hysteroscopically also any lesion is seen or any adhesions, or that can be dealt at the same time.
Yeah, true.
Also, these lectures, this series, Mr. Prasad, you give the recordings. Madhura, you put it on POGS website so that if people want to see it later on, listen to these lectures later on, they can then go there. Then we will just...
we'll circulate the message.
Yeah, thank you so much.
Thank you. Looking forward to...
Thanks to Dr. Charu Bape for conducting the entire program so well and so smoothly. Thank you, Charu.
Thank you, Vaishali. Dr. Prasad, Dr. Indranil, kasa hai Kolhapur sadhya? All good?
Yes, all
Kolhapur
good.
is always a happy place, ma'am. खूप चांगला आहे.
So well said, so well said.
Happening place, the most amazing food in the world. That's Alevi Kolhapur.
Every day when you walk out.
I don't know when you talk about Kolhapur.
Yeah.
Yeah, Dr. Indrani.
Here actually they are not seeing like की म्हणजे आता पैसे आलेल्या लोकांकडनं म्हणजे घेऊन त्यांना जेवण द्यायचं नाही, तो माणूस संतुष्ट पाहिजे जीवन, अशा पद्धतीने क्युझिन्स आहेत. आणि दुसरी गोष्ट म्हणजे हिल स्टेशन सारखं वातावरण नेहमी असते, सो इट्स व्हेरी काम अँड गुड. मस्त एकदम. या एव्हरीबडी इज इन्व्हायटेड टू कोल्हापूर OBGY सोसायटी.
Thank you so much. Thank you so much.
Nirav, stop recording. So we'll be offline now.
Yes, indeed.
Recording stopped.
So Indranil, we could not come with the Gardasil program, but at least